Welcome everyone to Mayo Clinic Q&A. I'm Dr. Helena Gazelka. We are back with another fascinating topic today. Mayo Clinic recently introduced a new care model called Advanced Care at Home. Using a new technology platform, some patients who had previously been treated in a hospital setting will have the option to receive their care and monitoring at home instead. Joining us today to discuss this is the Division Chair of Hospital Internal Medicine at Mayo Clinic in Florida, Dr. Michael Maniaci, who leads the Advanced Care at Home program. Thanks for being with us today.
Thanks for having me.
Well, this is a really fascinating topic to me, and particularly, I think, to our listeners in the time of COVID-19, because people don't want to go out and they don't want to have to go into the hospital if they don't have to seek their care. Will you give us just a little overview of what advanced care at home means?
Practicing medicine in the patient's home is not a new thing. 150 years ago, William W. Mayo was conducting home visits, but that was a time when medical technology was pretty simple. As medical technology advanced, hospitals were built to kind of centralize these resources, pharmacy, lab, therapeutics for the illest patients. Just like department stores centralized shopping or grocery stores and restaurants centralized food, it's the same concept. Bring the customer to the resource hub. One of the focuses for Mayo's 2030 strategy is the patient can see you now. This is a focus on individualized medical experiences for our patients and giving the patient more convenience. We're looking to flip the script on 100, 150 years of medical history. Just like Amazon does this now for shopping or Grubhub does it for food, bring it to the consumer at their home. Mayo Clinic is looking to do this with the practice of medicine of the hospitalized patient. And this program is called Advanced Care at Home, a new virtual hospital which we bring to the patient in their home.
What type of patients and conditions are best suited for care at home?
So the ideal patient population as we launch the program, which is about 2 months old now here, includes patients that are sick enough to be warranted to be in the hospital setting, while not so sick that they require surgery, invasive procedures, advanced imaging. On any given day, there's hospitalized patients with heart failure, pneumonia, cellulitis, bronchitis exacerbations. Those patients have medical conditions that require labs, medication therapy, infusions, and rounding by physicians or our provider extenders. And those are the perfect patients for this type of program. As we refine the model over time, we're able to expand our reach to different medical populations. We've started with these basic general medical patients up front.
How does the program work when a patient is sick? Do they go to the emergency room to get into this program or do they go to their primary care doctor? And then what kind of things have to come into the home equipment-wise?
Sure. So we started the program admitting from the hospital itself, meaning somebody gets admitted to the hospital, they're ill, and instead of staying 5 days, 7 days in the hospital, after 24, 48 hours, we move them to the home setting. But as we advance the program, it will be part of our technology package will be to move people from either the ED or even from the clinic if they're ill enough for hospital care, but again, don't require those advanced procedures or surgeries, moving them right out of those settings into their home. One day, we hope to treat people, diagnose them in their home themselves. They call in, we see them, we treat them, and if they need to be admitted to the hospital and home, just do it right then. But right now, we're just started with the hospital setting. There's really 4 key components that make this work. First is the technology package in the home. So we have to change the patient's bedroom into a hospital room. How do we do that? That's with the iPad that has some technology on it that makes it turn into a virtual workstation for our patients. That station is used as a hub to virtually connect to their physicians, their APP providers, their nurses, or any other consultant that wants to see the patient virtually, much like we're doing with the clinic right now with virtual medicine. That iPad is hooked up to a lot of Bluetooth technology, pulse oximetry, blood pressure cuff, pulse meter, scale, all these things that feed us back information into our technology hub. Now, all this technology and information has to go somewhere, so the second piece is a command center. The command center is like a virtual hospital ward. It's an area that houses the physicians, the APPs, the nursing staff, and some of the care coordinators. And as opposed to all these people trying to go house to house throughout the city, which is a very not efficient model, they're all hubbed in one area, and the patient comes to them through the technology. Linking these things is the software package. We're paired with a company called Medically Home, who invented a software package named Seisha The software package lets our computer EMR speak to the patient in their home. So it helps with the virtual connection. It feeds back labs, vital signs, everything. So we can see it just like we would look at a patient who is hospitalized. The final thing that really makes this work is the supply chain. So again, if you want labs, if you want infusions, we have to do that in the home somehow. And Mayo can build it all themselves, or we can work with the excellent medical community that provides these things regularly. So what we've done is we've paired with many community partners, both here and in Northwest Wisconsin, the 2 sites that we launched this with. And that supply chain is what delivers the care in the home that we provide. So I'm making the orders, writing the prescriptions, and then an infusion nurse shows up and gives medications through the IV. EMS shows up and does an exam and feeds me back information. That's how this system really works, those 4 key components.
How does care that patients receive at home differ from what they could receive in the hospital?
Sure. Well, first off, as I said, as of right now, we're not doing any advanced procedures. So the illest of the ill that require ICU care, intensive procedures or surgeries, we're doing that in the brick and mortar hospital and likely always will. We're treating general medical patients at home in 3 phases, really. First is called the acute phase. That's the part where patients usually are in the brick and mortar hospital for the first 5 to 7 days. Those days are replaced in the home where they're seeing me every day virtually. I'm having a lot of hands-on in the home, be it my EMS staff, my provider staff with APPs, or other people giving medical infusions, labs, intensive care in the home setting. After that intensive care is done, this is not a one and done, kind of like what we do in the hospital now. We own the patient for another 20 to 25 days after their care, called the restorative phase. We use that phase to educate the patient on their medical condition, their medications. We watch them in the home to make sure they're safe. We make sure they make their appointments. We make sure we talk to their primary care provider and any consultants that will see them in the future. And we use that time to hand off the care properly. So the patient really takes ownership of their care, and we know that they're seeing the right people after that 30 days is done. And that's really leads to the 3rd phase, which is the handoff to the physicians in the community that take care of these patients in the long run.
How do people end their hospital at home stay? And then I suppose the equipment is returned, et cetera, once the physician determines it's time?
So after about, that 25 to 30 day mark, we really make sure that we've met all our goals of the restorative phase. Again, goals in the acute phase when they're the illest is making sure the infection is out of their bloodstream, that they're breathing better and getting enough oxygen. The goals of that restorative phase may be ambulate in your house properly, make yourself a meal, show me you can do your medications, make your appointments on time, tell me about your medical condition and what you do if complications came up. Once they meet all those goals, about 25 to 30 days in, we're able to basically discharge them from the program, make sure their primary care provider follows up, then we go back to the home and collect all our technology, clean it, and use it for the next patient.
What would be enticing to patients about this? What benefits could they expect to see? I suppose monetarily, but also less tangible benefits.
Sure. Well, first off has to be the convenience. I mean, being in the hospital away from your home environment as well as family and friends is tough. On top of that, the hospital makes it difficult to recover at times with all the interruptions for nursing checks, vital checks, the custodial folks come in, lab folks come in right when you fall asleep, multiple care teams arriving at variable times. And if you didn't have all that, you have all the monitoring with the beeps and the squeaks to keep you up all night. It's a wonder that anybody gets any sleep in the hospital. In the home setting, you don't have that. You have a schedule, as opposed to the hospital where people kind of show up. When you're in your home, we have to schedule. When is physical therapy going to show up? When are you going to get that infusion? When is Dr. Maniaci going to call in and talk to you? The patient can't just be sitting around their house waiting for these things. So we give them a nice organized schedule and we eliminate all those extra annoyances that keep people annoyed in the hospital. Next, and my big thing is really safety. I mean, hospital errors result in serious harm events, hundreds of thousands of cases per year. Hospital-acquired infections affect thousands of patients. We hope by keeping people out of the brick and mortar hospital and by keeping them the care centered around an individual in their own home, we can reduce these errors and provide a safer, more individualized care environment for them. And then an additional benefit related to that is the safety benefit in the timing of COVID. Right now, a lot of hospitals are kind of in lockdown. They're not allowing procedures. Patients feel isolated in their home. You can have in the home who you like. We keep seniors out of the hospitals and people with immunocompromised immune systems out of the hospitals, which keeps them protected. Meanwhile, the system keeps those patients at home, so we open beds up for the patients that need it the most, especially our COVID patients.
I know this is a relatively new program for Mayo, but Are we seeing improvements in patients' recovery times, or do you anticipate that we will in the future?
Just from a patient experience standpoint, the patients love the program thus far. We've enrolled about 12 patients through the program thus far. They're telling me they're getting better night's sleep. They get to rest in their favorite chair. They get to watch the shows they like, talk to their family. They have the freedom not only to, do what they do around the house, but also take an active part in their hospitalization. Because it isn't the intense hospital care setting that we set up in a patient room, they feel obligated in their own home to show me their medication, show me how they take them, really give me the feedback that they're taking an active role in their recovery. They've really enjoyed that.
So I understand this is probably on a limited basis at this point, but what do you see for this in the future? Where is it available now? Is it only available to Mayo Clinic patients, or do other patients have similar opportunities? And where do you think it's going in the future?
I think virtual medicine in general has had a strong future as a standard of healthcare. It's been accelerated in its implementation by COVID itself, and it's justified it. But this is something we've been thinking about and working on. Our own program we've been working on for the last 12 months, and we've implemented around the Florida area and Northwest Wisconsin related to Mayo patients right now, although we can expand that to other patients in the future. We'll talk about that in a second. We have to get to a different level of mentality when we look at medicine. We have to look at medicine differently. We know that with the growing world population, aging of American population, more healthcare is going to be necessary over the upcoming decades. But more healthcare, more medicine doesn't equate to build more hospitals. And that's the big jump we have to kind of get over for this virtual hospital to work. Building physical hospitals costs hundreds of millions of dollars. Organizing medical supply chains to deliver care in the home costs much less and really can be reached out anywhere. Theoretically, with this system, in a single day, I can take care of patients where any supply chain exists. Right now, it's Florida and Northwest Wisconsin, but tomorrow it could be Georgia, it could be California, it could be Spain. I mean, you really have limitless expansion of your reach because the medical supplies and supply chain have to be around the patient, but the virtual connection, the technology that makes it work, and the care that's housed in the command center really can reach across oceans if it wants to. But just because we build the supply chain doesn't mean we're just good and done. We don't build a hospital and say we're done and just shove off. We have to look at quality, safety, just like we do in the hospital with our supply chains. We need to hold them to a Mayo Clinic standard with our patients. As we grow, we need to refine, evaluate, and optimize these supply chains to give better care than even what we give in the brick and mortar hospital now. But this is just one tier of virtual medicine, the hospitalized patient. But we're seeing different tiers of primary care providers doing home visits through virtual medicine, nursing staff doing that. I think, the virtual grasp has really caught on through what's happened with this pandemic. If one good thing has, come out of it, it's lit a fire in us that we have to take off with this virtual medicine on many different tiers and levels. And I think these will all be integrated over time. And people really, they'll only have to come to the hospital if they need a procedure or need something.
I have to agree with you about the virtual medicine. I have been astounded by many things during COVID and the progress that's been made, the publications in the scientific literature, but the incredible impact of increased virtual medicine is amazing to me. Obviously, we have a lot of patients come from all over to see us, and I practice pain medicine, and I've been amazed by how many patients have enjoyed the opportunity to have a virtual visit, either to help them understand what their upcoming visit will bring them and what they could expect from care at Mayo Clinic, or to be able to follow up with them when they return home in a way that we could not before. So what is the biggest challenge that you face moving forward with care at home?
I think like any change management issue, this is a new system of healthcare. It's innovative, but it's also disruptive. Patients may feel hesitant to go, quote, home at first, even though they require hospital level care. Likewise, us providers may be hesitant to let their patients out of their sites when they're that ill. But I really believe over time, as we grow this and people see the successes and the quality and safety and patient satisfaction, the reduced costs that come with it, eventually it'll be our patient's expectation not to be admitted to the hospital. They'll want to be taken care of in the home, just like we do with shopping and food and everything else. People will want that experience. They'll want an app where they can call their doctor, do a visit, and if they need more intense care, let that, be happy that that's going to show up in their home and they're going to get the same care that they would in a Mayo Clinic hospital. I think that's quite exciting, but it's scary to a lot. As you say, I think the patients are dealing better with it right now than us providers are.
Having spent plenty of time in hospitals, I have never ceased to be amazed at how much patients want to get out of the hospital. Understandably, if you sat on one of those vinyl chairs for very long, you know that their living room would have to be more comfortable, or their own bedroom. And so it's an amazing concept, and we appreciate you sharing it with us today.
Absolutely. No, our pleasure.
Our thanks today to the Division Chair of Hospital Internal Medicine at the Mayo Clinic in Florida, Dr. Michael Maniaci. He leads the Advanced Care at Home program for Mayo Clinic in Florida, and it's exciting to hear about this today. Thanks to all of you as well for listening in today and joining us, and we wish you a wonderful day.
Mayo Clinic Q&A is a production of the Mayo Clinic News Network and is available wherever you get and subscribe to your favorite podcasts. To see a list of all Mayo Clinic podcasts, visit newsnetwork.mayoclinic.org. Then click on Podcasts. Thanks for listening, and be well. We hope you'll offer a review of this and other episodes when the option is available. Comments and questions can also be sent to Mayo Clinic News Network at mayo.edu.